Let's do passive range of motion to the right lower extremity. First, we'll expose the limb, just the one, to keep the patient good and warm. I'll lift up a little bit at the knee, take the tip of the bottom of the sheet covering them, pull it through the knee and back up for privacy and modesty. For starters, we can have the knee straight up and we can work on, for passive range of motion, it's all therapist and the patient's just cooperating. And so you can have your hand here on the 4th and 5th metatarsal. If it's passive range, there's no stretch. If there is stretch involved, then we actually notate it as stretched. So we can do dorsiflexion and plantar flexion. If needed, we can do eversion and inversion. Moving up to the knee as a hinge joint, you're going to go one hand above the knee, one hand below, and for the flexion and extension. These are passive with the patient in supine. Next up for the hip, you saw some hip flexion there, but if you had the knee slightly unlocked and flexed, you could take the hip into higher flexion. If you do range of motion to the hip and flexion, you must have a hand on the ASIS to tell if it's all hip or if you're getting more lumbar spine. So hand on the pelvis, and when you start to feel the pelvis rotate, the hip flexion is completed for documentation purposes. Anything more than that is lumbar flexion. Okay. Next up, abduction. So depending on the surgical precautions, you may or may not be able to adduct, but you come to the side and back in. So I have a hand on the thigh, a hand on the lower leg. You may have to put one hand on the inside if the leg is trying to rotate, to keep the rotation out. When you're going to flex, you've got to have, your hand is going to have to rotate this way. So we may show that on the other side. So you've got flexion, abduction. For rotation, rotation's coming out of the hip, so we're rotating the limb externally and internally, making sure that you're getting the rotation out of the hip and not out of the tibia.